Good evening, ladies and gentlemen, and welcome to the Miracle of Living lecture this evening on dizziness, vertigo, and hopefully understanding same. We have two speakers this evening, and I'll introduce them one at a time. Our first speaker is Dr. Jie Pan. She completed her neurology residency training at Texas Tech University Health Science Center, and then completed her fellowship training in epilepsy at the University of Texas Southwestern Center. She earned her medical degree from Southeast University Medical College in China. Dr. Pan also obtained a PhD from Nanjing University, followed with research experience at the University of Texas, Austin, and Stanford University in the field of neuroscience. Her prior research has yielded several publications that have been invited to present at several American Academy of Neurology conferences. Dr. Pan is interested in general neurology, specializing in epilepsy, cognitive impairment, and movement disorders. In her free time, she enjoys hiking, reading, and spending time with her family. She's also, in case you have questions in Mandarin, she's fluent in Mandarin. So at this time, please welcome Dr. Pan.
Thank you very much, and good evening, everyone. I am Dr. Jie Pan. I am very delighted to give this talk here about dizziness and vertigo. So this is a very broad topic, and we're going to focus on the most important and common situations that we see in clinical scenarios. And I will try to make this talk as informative as well as easy to understand as possible. So in the next 30 minutes or 20-ish minutes, we're going to talk about what is the difference between dizziness and vertigo, what are the common causes for vertigo, what are the causes for dizziness, what are the common causes for vertigo, and what are the common diseases causing central vertigo and how to recognize them, and what are common diseases causing peripheral vertigo. So don't worry about the term central vertigo or peripheral vertigo. I'm going to explain that in a little bit. So first, what is dizziness? Dizziness is a very common symptom that patients come to clinic. It is a very non-specific term that can be referring to misperception of a spatial orientation. But as we mentioned, it is very non-specific, so it can be referring to a lot of things such as swaying, tilting, or the feeling that about falling. The majority of the patient, 2/3 of the patient, we don't have a spotlight here. Okay, 2/3 of the patient with dizziness falls in the age group of 40 to 70 years old, and patients who are older than 70 years old accounts for less than about 20%. So being saying dizziness is a very non-specific symptom, vertigo is a much more specific term, which means the room is moving or spinning around you. Some people say it's it's one of the type of dizziness, but it's being more specific because it's caused by problems that caused either in our inner ear or the brain. By saying this, so if we are talking about dizziness, then the differential diagnosis list, probably there are 100. But if we're talking about vertigo, the list probably will decrease to about 20-ish. So I always tell my patients that if you are sure that you have vertigo, for example, if your previous doctor tells you that you're having vertigo, it's great to use this term. But if you are not sure, just instead of using this term, tell us what you feel, such as do you feel room spinning, do you feel you're tilting, instead of using vertigo, this term, because it's good to use a very specific medical term. But if not using that correctly with some misunderstanding, that can lead to a different route and miss some important diagnosis. So like I mentioned, you can just tell us, what do you feel? Do you feel spinning? The room is spinning around you? Do you feel tilting, swaying, or off balance? And a lot of times we have symptoms happen together. We have more than one symptoms. Vertigo and dizziness, you can have both. And you can also have lightheaded, which is near fainting experience. You could have vision getting blurry or vision getting darker. And off balance is also very commonly reported by patients as well, that you feel like you will fall. But off balance by itself can cause by a lot of different factors. There are a lot of other features to take into consideration to be able to reach the right diagnosis. For example, is there any important history before the onset of the dizziness? Do you have any head trauma, any fever, any infection? And is your dizziness comes and goes, or it is continuous? And is your dizziness last for seconds, minutes, hours, or days, which all makes a difference? And is it worse when you move your head or when you change your position, especially a head position? And is there any other associated symptoms, such as nausea, vomiting, headache, sensitivity to light or noise, hearing problem, ringing in the ear, double vision, trouble speaking, swallowing, or weakness, especially weak on one side, and shortness of breath, sweating, or heart racing. So all those informations are very important from you to us to help us to reach a right diagnosis. So what are the common causes for dizziness? Dizziness here, it means non-specific dizziness, not vertigo. So most of them are systemic causes. For example, hypotension, which means blood pressure is low, which can be caused by dehydration or medication that affect your blood pressure. And I want to mention that hypotension being seen this way is mainly we're talking about the change of your blood pressure from your baseline. For example, my blood pressure systolically probably stays at 100 all the time and I don't feel dizzy. But if someone has a blood pressure at baseline 140 systolically and sees his very nice cardiologist and get a blood pressure medication and drop to 120, and he will probably feel dizzy, is the change of blood pressure. Hypoglycemia, which means low glucose. Our brain can only use glucose as the source of energy. It cannot use fat or protein directly, unfortunately. So we'll have the experience that if we miss a meal, we will feel dizzy. That is because of this. And it's more common in patients with diabetes, so who, especially those who are insulin dependent. So glucose monitoring is very important. So anemia, which means low red blood cell count, is the same meaning. Our red blood cell carries the oxygen to the brain to provide the oxygen supply. Also, static hypotension, which just a fancy term, means your blood pressure dropped too much when you stand up too quickly. And heart problems, such as irregular heartbeat, atrial fibrillation, heart failure, all cause this dizziness. Medication side effect, very common. It can be medications from us, neurologist, or any other of your primary doctor or any specialty doctor. Yeah, and it's also common when some people are taking a lot of medications. So medication interactions can make things more complicated. Anxiety, hyperventilation, non-specific causes. So those symptoms those causes that for dizziness are already almost always addressed by your primary doctor. So they will figure out the problem. And when the patient come to us, are usually more specific vertigo. So actually vertigo is very simple. There are just two types, not like dizziness. There are so many different kinds. So vertigo, just central vertigo or peripheral vertigo. Central vertigo means the problem is from the brain and the peripheral vertigo is from inner ear. So because my colleague and I are going to try to cover this topic from different aspects, so I'm going to talk more about central vertigo, and he's going to cover more about the problem from peripheral vertigo, the inner ear. So central vertigo, where is the problem? we know that it's from the brain, and to be more specifically, it's from the brainstem and the cerebella. So where is the brainstem and cerebella? So we know that our brain has two hemispheres, left and right. And as we can see from the middle of this, the middle of the picture that we are viewing, the middle one that we're viewing from the left side is a sagittal view. The pink part, the big part is the hemisphere, and the brainstem is the small part inside, in the middle of the both sides of the hemisphere. And the cerebella is the one that is sitting on top of the brainstem. And if we look at the right picture, if we cut the brain in the middle and look from the left again, and we can see the correlation from the hemisphere and the brainstem and the cerebella. And if we take out the brainstem, and that is how it looks like on the left side. But that upper part is thalamus, to be accurate. So we know that our hemisphere, we sometimes call it cortical areas, provide a lot of higher function of our brain, which makes us human. For example, memory, language, emotion, and complex vision. And brainstem is also very important. It provides a lot of basic functions that makes us alive, such as breathing, heart rhythm, swallowing, and balance is one of them. Of course, it's related with the cerebellar area. And another important thing about brainstem is all the nerve fibers that travels from our brain to our body has to come together into a very dense bundle, and then go through the brainstem and through our spinal cord and then to all over our body. Just imagine that as an intersection for a highway that comes together. So by saying that, if there's a small lesion that happens on the brainstem, even if that's very small, it can cause a lot of functional damage. So by saying back to our topic, central vertigo, that means the lesion that happens in the brainstem and in the cerebella that is we feel vertigo, making us feel vertigo. So what are the problems? What are the diseases? What are central nervous system disorders causing vertigo? So the first one I want to mention is not the most common one for most common cause for vertigo. It's just the most severe cause that I want to mention is stroke and transient ischemic attack of posterior circulation. I'm going to explain what it means. So transient ischemic attack, TIA, some people call it mini stroke. The difference between stroke and mini stroke is the later one symptoms resolve in 24 hours, and it does not leave a permanent scar in our brain. And on the other hand, stroke will leave a permanent scar on the brain. And that is the posterior circulation stroke, or the TIA, causing this symptom of vertigo. So our brain, as we can see from the right, the picture, is the blood supply is from 4 vessels, and 2, like in front of the front ones, are called internal carotid arteries, which supply the blood supply for the cortical area that we saw from the previous picture. And the 2 in the back, which lies inside the bones, are called vertebral arteries, that supplies the brainstem and cerebella. And the problem is from those 2 arteries. So the symptoms is acute sudden onset of vertigo, and it is continuous. It's not associated with positional changes or head moving, and often associated with other symptoms like weakness of one side, facial droop, slurring speech, difficulty swallowing. Not all of them, but maybe some just having slurring speech and difficulty swallowing. And the reason is what I explained, because the brainstem is controlling all those important functions. And risk factor is the same as other stroke, like hypertension, hypolipidemia, diabetes. One more thing I want to mention that is also a cause for posterior circulation stroke is vertebral artery dissection, which is not common, but the symptom can be very subtle and can be missed if we miss a history. And it's caused by trauma of the neck and sometimes neck neck manipulation. And a symptoms is headache, head pain, neck pain, dizziness, and vertigo. So look at those vertebral arteries that goes in between those canal of the vertebral bones to see how narrow, how tight those space are. So imagine there is a trauma or twisting or tilting that can lacerate the artery and causing the problem. So I always tell my family members that if you want to go for a massage, that is fine. You can touch the head, the shoulder, the back, but just don't touch the neck part. So ischemic stroke and hemorrhage stroke can be caused by ischemic or hemorrhage. Those are just two different types. The clinical symptoms can be very similar. We need the imaging to differentiate them. And this is medical emergency and go to call 911, go to ER to be addressed. The next thing I want to talk about is vestibular migraine. So people who have migraine all know what migraine means. It is headache, but much worse than that. And migraine can be associated with vertigo or motion sensitivity, and it is one type of migraine. And the headache can come later, can come together. Most of the time, it comes later than the vertigo spells. One specific thing about migraine vertigo is the duration is very various. Can be minutes, can be hours, or can be a couple of days. And even for the same person, the duration sometimes varies as well. That's why it makes it a little bit difficult to diagnose. But it's usually associated with headache, nausea, light sensitivity, sound sensitivity, or visual symptoms, which is similar as the other type of migraines. And usually patient will have a history of migraine as well. Other causes for central vertigo, like tumor, multiple sclerosis, meningitis, neurodegenerative disease, such as Parkinson's disease and seizure. Those are very rare. We're not going to talk about that today. So then we talk about peripheral vertigo a little bit. So peripheral vertigo, the problem is from the inner ear. On the left side of the picture, you see a little cochlear, looks like a snail there. And on the right side, we just put it outside to have a better look. And it is filled up with fluid. And also there are thank you. There are three semicircular canals, anterior, posterior, horizontal, that there's little calcic stone over there. So if there's problem with the fluid or the stone, that can cause vertigo. So BPPV, benign paroxysmal positional vertigo, is the most common type of vertigo. I just like this name. It tells what it means by its name. So first is benign. It's not a tumor, not a stroke. And it's paroxysmal. It comes and goes. And positional changes make it worse. And it's a vertigo by definition. And it's caused by misplacement of the inner ear stone, as we just mentioned. The symptoms is episodic of vertigo triggered by positional changes and can last seconds to usually less than 1 minute. So very typical presentation, patient woke up and sit up and feel the room is spinning, but it passed in about a minute. But when he lies down and it comes back, so patients are very reluctant to move their head. Peripheral vertigo, number 2, Meniere's disease, which are more seen by ENT clinic more, I believe. It's because of the buildup of fluid in the inner ear and also episodic of vertigo. And the difference between from BPPV is you will have more hearing problem, hearing loss, and feel fullness in the ear. And third one, vestibulitis, labyrinthitis, very similar. I think the difference is labyrinthitis have caused more hearing problem. The cause is viral infection, and the vertigo is very severe, associated with nausea and vomiting, cannot walk, and it will gradually resolve. It's just like you got a flu in your ear. So talking so much about the dizziness and vertigo, and we don't have a magic lab test to tell us what is the diagnosis of your vertigo, unfortunately. So the diagnosis is largely based on the history and the detailed story that you guys provided to us. And also the physical examination also provide us a lot of information, especially the eye movements. We call nystagmus. So don't be surprised if we check your eyes a lot in clinic. And we sometimes need MRI to rule out brain lesion, especially this is a new onset of vertigo and it's persistent. And we sometimes also need a hearing test as well. So the treatment is based on the diagnosis, especially for the central vertigos. Different causes of vertigo will be treated differently, like stroke, multiple sclerosis. Those things will be treated differently. For peripheral vertigos, vestibular rehab is the major way to treat this issue. This is just a bonus bonus slide that show people who likes to say data, is to show what are the common causes for dizziness that comes to patient with dizziness that come to a clinic, and what is the percentage. So those are from the previous studies that were done many, many years ago, but it should be still similar right now. So vertigo is about 50% among all the studies. And BPPV, the second red box that I checked out, is about 15-16%. And central vertigo is less than 10%. So not that common. Most stuff are benign. In summary, dizziness and vertigo are common symptoms of many possible diseases. It can be caused by benign or dangerous conditions, though most of the conditions are benign. So if you have the symptoms, visit your primary doctor first, and you may get referral to neurology clinic or ENT. And one specific thing from this topic is vertigo due to stroke and TIA are medical emergency. And need to be addressed immediately. So thank you very much. I hope this is helpful and you guys get some information from this talk, and we are open to questions. Thank you very much.
Thank you, Dr. Pan. I certainly learned a lot. I hope everybody else did too. Our second speaker this evening is Tim Baker. Tim received his bachelor's degree in exercise physiology from DeSalle University and then went on to obtain his doctorate of physical therapy degree from Arcadia University. Both of those universities are in Pennsylvania. Tim believes in providing evidence-based care to ensure that his patients are receiving the most effective treatments. For that reason, he continued on after graduation to achieve national board certification as an orthopedic clinical specialist, as well as his certificate in vestibular rehab. I'm looking forward to figuring out what that is, through Emory University. Tim has enjoyed treating both orthopedic and vestibular patients of all ages through his career, and he enjoys the challenges of diverse patient cases, which requires collaborating with each patient to ensure specialized care in helping to meet their specific functional and personal goals. Please welcome Tim Baker.
Thank you for that, and thank you for that great presentation, Dr. Pan. A lot of the stuff that I'm going to be talking about for the peripheral side, we'll get a little review there, so you'll have some time to digest it a little bit more. All right. So dizziness and balance disorders are the most common reason for a visit to the doctor's office in patients above 75 years of age. And it affects 20 to 30%, dizziness affects 20 to 30% of the general population. And of this 20 to 30%, about 1/4 of these complaints are vestibular in nature, and vestibular meaning that inner ear related dizziness. Over 35% of adults over 40 years of age have vestibular dysfunction, and that accounts for about 69 million Americans. And then about 75% of persons with balance or fall issues actually have a vestibular dysfunction, whether they know about it or not. If they were to get treatment for it, it could help reduce that fall or balance risk. So as we learned, there are many causes of dizziness. On the left-hand column here, these are the ones we're going to focus on related to the vestibular system, which is just a fancy term for that inner ear. The ones in bold are the ones that we'll focus on. Dr. Pan did a great job discussing more of the neurologic. She touched on some of the cardiovascular, such as dehydration, orthostatic hypotension, which is that fancy term for that postural dizziness when you change positions too quickly and your blood pressure drops. Abnormal heart rhythm, such as atrial fibrillation, congestive heart failure, or any heart flow issues. Infections, that low red blood cell there that carries the oxygen, low blood sugar, low thyroid, and certain medications that cause dizziness, as well as certain medication interactions. So again, I started this slide here because I think it's very important. When we say dizziness, it's a very non-specific term. So we want to be very specific when we're seeing a provider to describe what we're actually feeling. Because a lot of people will come in and say that they have a diagnosis of vertigo, but it's very important to note that vertigo is not a diagnosis, it's a symptom. So it's describing that illusion of movement within your environment. And that tends to be a rotational or spinning sensation. We also have lightheadedness, which is described as a wooziness or faintness or feeling disconnected from the environment. And then we also have disequilibrium, which is more of a unsteadiness on the feet or an imbalance, maneuvering within your environment, often without any type of illusion of movement. So it's very important to be specific about these terms. And as Dr. Pan mentioned, if you're unsure of which term to use, just describe your symptoms in lay terms is the best way for us to kind of figure out what's causing your dizziness. Again, history is key. So we don't have lab tests or imaging that's going to give you a specific diagnosis. Most of these diagnoses are determined based on what you tell us, so patient history. So it's important to make the distinction between the different types of dizziness, vertigo, lightheadedness, or disequilibrium, which we touched on. It's important to know the duration of symptoms because that cues us into what type of dizziness that we're looking at. So is it lasting seconds? Is it lasting minutes? Is it lasting hours? Or is it lasting days? And then are these episodes continuous? Are they nonstop? Or do they come and go? Are they episodic? And then again, are they coming on at random? You're just sitting there doing nothing? Or is it related to when you roll in bed or you look up or you bend down? So head or body position. And then other things we want to know about that'll cue us into different diagnoses are there any hearing symptoms associated with your dizziness, such as hearing loss, ringing, or medical term of tinnitus in the ear, or any ear fullness? And we also want to know if that's, a lot of people have hearing loss, but it's that age-associated hearing loss, that high-frequency hearing loss that we get as we age. But we're looking kind of more at, is it a one-sided issue where you always get the hearing loss, the ringing, or the fullness in that one ear? And is it associated with those dizzy spells that you're presenting for? And then other associated traveler symptoms, which would be nausea, vomiting, headaches, heart palpitations, feelings of panic or stress, difficulty speaking or swallowing, or some type of asymmetric one-sided muscle weakness, whether it's the arms, the legs, the facial droop. And then were there any precipitating events leading up to your dizzy spells? Was there a recent illness, upper respiratory infection, or ear infection? Was there any head trauma? Did you have any sick contacts recently? Or medications that might be toxic to the inner ear? A lot of the chemotherapy medications or strong antibiotics like a gentamicin, if you were given that type of medication, that could have a detrimental effect on the balance system of the inner ear. And then we also want to find out, do a thorough medical history. So do you have a history of migraines? Do you have any endocrine disorders, cancer, heart disease, or any other systemic infections that we should be aware of? So we spend a lot of time the first encounter to really get a thorough medical history, because that's going to kind of lead us into the diagnosis. And by the time we take that history, we have a pretty good idea of what type of dizziness you're coming in for. And then we're doing our clinical exam and our testing to confirm our hypothesis. So just a quick anatomy lesson. I'm going to keep it simple, but the vestibular system is, again, just a fancy term for that inner ear balance system, okay, as we see here. So we have our outer ear here, then we have our ear canal, which is where we get that wax buildup. Then we have our eardrum right here. So what we're referring to for the vestibular system is deep to that eardrum. So we can't get inside there or see inside there unless there's a hole in that eardrum. And then we have the little bones of hearing in the middle ear, and then deep to that, surrounded by the temporal bone here. All of this in real life is about the size of a dime. And when we get to talk about these crystals are smaller than dust particles, but they cause really big problems. So we have the hearing organ, this little snail organ here called the cochlea. We see two of them here, the other one's hidden, but we have 3 half-circle fluid-filled canals, and then we have this utricle and the saccule, which is where those crystals are supposed to live. And then leading to the brain, we have a vestibular nerve, which is that nerve of hearing, and our cochlear portion of the nerve that supplies our, vestibular, which supplies the balance, and cochlear, which supplies the hearing. And together, it's one of the 12 cranial nerves, the 8th cranial nerve, that vestibular cochlear nerve that supplies both. And the function of this is to maintain balance, equilibrium, spatial orientation, and keeping clear vision whenever we turn our head. So if we didn't have a properly functioning vestibular system, every time we turned our head, our eyes would have to play catch up. So we'd have kind of a jumpy vision. So maintaining balance is actually a very complex process, but to keep it simple, what I like to say is that we have 3 main systems for balance. We have our visual system, being able to see. We have our vestibular system, which is what we're going to focus on, which detects rotation, translation, and gravity. So it's whenever we turn our head side to side, up and down, or tilt, we're sensing this with the 3 fluid-filled semicircular canals. And then the utricle and the saccule that we touched on detect acceleration, deceleration, that linear movement. And then the saccule responds to gravity. And then we also have pressure sensors, or our somatosensory system, that detects the surface that we're walking on. So if we have something like neuropathy and we're not getting that proper input through the foot, then we're going to have balance issues. All 3 of these systems receive the signal from whatever that body system is doing. It sends a signal to the brain, and then the brain sends an output message to correct our eyes and to correct our posture so that we can maintain our balance and not fall over. So when we have vestibular system dysfunction, some of the things that we might feel right here, symptoms, something that you might report, is disequilibrium, oscillopsia, or jumpy vision, or an abnormal sense of movement or orientation, which are those kind of types of dizziness that we reviewed. And then signs would be something that someone can outwardly see. They might notice that you're having balance difficulty, or walking abnormalities, or reduced visual acuity during head movements. So if we don't have a proper functioning vestibular system, when we turn our head, we would have that jumpy vision. So we're going to talk about vestibular rehab in this lecture for the treatment. And with each diagnosis that I'll go through, I'll touch on a little bit of the treatment for each. But just in general, vestibular therapy is a subspecialty of physical therapy. So we have physical therapy at the top, and then certain, if you're interested, a therapist can go on to receive further training outside of our graduate coursework to become more specialized in treating balance and inner ear disorders. Vestibular therapy consists of, it's not a one-size-fits-all approach. So that's why it's important to figure out what's causing your dizziness, because there's a different treatment for each. So we do a thorough clinical exam to determine the cause and develop a unique treatment plan to address the cause and the presentation, the symptoms that you're presenting with. So I'm going to talk about the 3 common peripheral vestibular disorders, and then another common one that we see that is not necessarily peripheral, but has to do with the vestibular system, is the vestibular migraine that Dr. Pan touched on. So first and foremost, we're going to talk about BPPV. It's the most common cause of dizziness. And again, it's a tongue twister. But if you break down the name, benign means it's not life-threatening. Paroxysmal means it comes in sudden but brief spells. So usually seconds, not more than a minute, although it might feel like that sometimes. Positional, it usually occurs with position changes like rolling in bed, looking up, or bending down. So if you have dizziness with rolling in bed, you have about 4 times more likelihood that you're experiencing positional vertigo, the BPPV. And then vertigo is just that term for the spinning or rotation. So it's caused by those otoconia or crystals that are out of place in the inner ear. The otoconia are actually a normal part of the inner ear. We need them to maintain our balance. They don't just show up and cause problems. They cause problems because in the normal functioning ear, they're supposed to sit, if you look at this picture on the left here, these crystals right here are supposed to sit on a little gel layer. At the bottom of that gel layer, we have little hair cells. Those hair cells go down and extend, and they attach to nerves. Those nerve fibers travel and send that signal to the brain. So when we tilt our head backwards, the crystals pull on that gel layer that they're stuck to, and that tugs on the hair cell. The hair cell sends a signal to the nerve, and the nerve travels to the brain, and we know where we are in space because of that signal. Same thing when we go forward or when we accelerate or decelerate here. So with BPPV, a common presentation is going to be severe room spinning dizziness, usually lasting seconds, occurring with rolling in bed, looking up, or bending down, as I mentioned. There should not be any hearing changes with this. And it's important to note that it's not always one diagnosis that you might be presenting with. So you could have BPPV with any other of these coinciding diagnoses. So if you have hearing changes, you might have BPPV, but you are probably having something else going on that would need a further workup. And the way we diagnose this is, again, that patient report, what you're telling us. So you should be telling us these things, and it should be leading us into a clinical exam to confirm that. And the gold standard diagnosis for diagnosing BPPV is this positional testing, which I have some videos to show. And the treatment maneuver, or the treatment, is repositioning maneuvers. And if you've heard of the Epley maneuver, just a second, technical difficulties. But if you've heard of the Epley maneuver, it's because it's the most common treatment maneuver, most effective treatment maneuver for the BPPV. Thank you, Mitch. All right. So the picture that was going in the corner there, these little crystals right here are supposed to be stuck to this little yellow jelly bean looking thing. Because they're not, they're just sitting on the ledge. So when she goes to lay down, these crystals fall into any of these 3 fluid-filled canals. And as they travel through that fluid where they're not supposed to be, it sends a false signal to the brain telling us that we're dizzy. And we're dizzy until those crystals settle to the bottom of the canal, and then they eventually stop. So that's why our dizziness only lasts seconds to less than a minute. So what we do to diagnose it is what's called the Dix-Hallpike test. We lay down. These crystals right here are floating through the fluid. And we're watching either in room light or with specialized goggles to magnify the eyes for an involuntary eye movement called nystagmus, which is essentially kind of an eye twitch. And these, the type of nystagmus right here, what you're seeing, for this positional test should have kind of a rotational movement to it, because this test is the Dix-Hallpike test is testing the anterior and posterior fluid-filled canal. So we would expect to see some type of torsion up or down. And then she's actually going through the Epley maneuver. So as she's turning her head here, the crystal's floating. So we're using gravity to float that crystal around to get it back where it's supposed to be. So this is a picture of the Epley maneuver. What you would do if you had BPPV is sit in the middle of your bed with a pillow behind your bottom, turn your head to the involved side. So this would be the left side, lay back. And then that's that Dix-Hallpike position. So that's the testing position. You would wait there to see if you're dizzy. And in each position, the longer you wait, the better, because the longer those crystals have to settle. So each position you want to wait for 30 seconds to a minute, and then you would turn your head from the left to the right. So now she's with her head over to the right side over the pillow, and then rolling onto your right side, waiting a minute each position and sitting up, and that's one treatment maneuver. The success rate for this is very good. It's 80% within one treatment and 96% within 3. So this is a very treatable. But we also have 3 fluid-filled canals. So with the Dix-Hallpike, we test for 2, and we also have this supine roll test, which, as you see in this eye movement, you don't have that rotational movement. We see just a horizontal kind of side to side. And that indicates that it's not that anterior or posterior canal, it's the horizontal. So it's a different treatment. We would use there's multiple different for each area of the crystal being out of place, but one that I like to use is Gufani. It's pretty simple. It's important to note that there is about, depending what literature you look at, 15 to 25% recurrence rate for BPV. So it is likely that at some point it will come back. And we can kind of reduce the recurrence rate with regular exercise, physical activity. And if you're deficient in calcium or vitamin D, it would be a good idea to talk to your physician about this, supplementing with them, because these crystals that we talk about are calcium carbonate crystals. The second one is vestibular neuritis or labyrinthitis. And this is the sensation that you would feel at this is kind of an abrupt, sudden, severe room spinning. And this is going to last hours to days. It usually peaks within the first 2 to 3 days. And initially, you would have symptoms constantly, even at rest. And then as it gets better, the brain understands that there's an issue. It kind of compensates. And then your symptoms really only come on with head and body movements provoking it. With neuritis, there would be no hearing changes, but with labyrinthitis, so this would be a picture of neuritis because that's the nerve going to the balance system. But if it were to affect the hearing nerve, the cochlear portion, we would have some type of hearing symptom, whether that's hearing loss or ringing. And to diagnose this, again, that patient report is key. Clinical exam, we have some tests that I'll touch on that we do in the clinic to confirm. And if there are hearing symptoms, sometimes we want to make sure that it's not caused by, usually it's a benign tumor called a vestibular schwannoma or an acoustic neuroma, which is a benign tumor, means it's not life-threatening, but it can push on that 8th cranial nerve there and cause hearing symptoms. But more commonly, we see an audiogram if there's any hearing symptoms to detect the intensity of that hearing loss, and then what's called a VNG or a vestibular nystagmography. And it's essentially a fancy test where they put goggles on you and have you track different targets on the wall. And then the test that we're really looking at there is called a caloric test, where they put warm or cold air or water into your ear. It's not a fun test, but it gives us a percentage weakness of the vestibular system in each ear. So we have a pair of the vestibular system, right and a left. So when we have inflammation or irritation to the one nerve, these pairs are supposed to be firing at the same rate. And when we have inflammation or irritation, we have a weakening of one side. So we have a reduction in that vestibular function, and it causes kind of a mismatch and essentially vertigo and dizziness. And whenever there's dysfunction to the vestibular system, it's one of our three main components of balance. So we also see balance dysfunction as well. So the treatment for that is vestibular rehab. And if you have either of these, you're more at chance of developing BPPV because you're having damage to the inner ear function, the inner ear organ, and that's where those crystals live. So the thought is that there's kind of a weakening of that system. And then some of the treatments, so this is a classic presentation of someone with vestibular neuritis or labyrinthitis, someone who wakes up with severe room spinning, may or may not have nausea, vomiting. Initially, it's a constant spin at rest, but it peaks over the first 48 to 72 hours. If caught early, sometimes physicians can prescribe a steroid pack to reduce the inflammation or the damage to that nerve. And then it usually improves to only provoked by head or body movements. Sometimes it is preceded by an upper respiratory infection, usually viral, but in the case of labyrinthitis, sometimes it can be bacterial, like from a middle ear infection. And it's a self-limiting condition. So a lot of times people have this and they never really need to go to vestibular therapy because their brain does such a great job compensating. But for those that have continued symptoms over time, those are the ones that we can do exercises with to kind of push that brain to compensate. And it's always good to start early and not just wait to find out if your brain's going to do a good job. But essentially, as I talked about, it results in an inner ear weakness, and that's where vestibular rehab can help. So some of the exercises, some of the clinical tests that we use is a head impulse test to test the function of the vestibulo-ocular reflex, or the VOR, which is the connection between the vestibular system in the ear and the ocular system in the eye. It's a very fast reflex. So what we have you do is focus on our nose, make sure you don't have any neck issues before you do this. And then we just turn your head quickly to one side without telling you, but your job is to just keep your eyes focused on the target. And if your eyes in a normal functioning vestibular system, the eye should be able to maintain fixation on the target. And if you have an abnormal vestibular system on one side, then that weakened side would have to correct to refixate back on that target, and we would see the eye jump back. Another clinical test that we do is called the Fukuda stepping test, and essentially you're standing with your eyes closed, arms out in front, and marching in place for about 50 steps. I usually don't do that, but that's what the test is validated at. And we're looking for essentially a deviation of 45 degrees to the right or the left, and that would tell us that there might be a vestibular weakness on the one side. And it's without your visual input, you don't know that you're rotating until you open your eyes. So treatment, a lot of it is targeted at that VOR, that vestibulo-ocular reflex that's been damaged. So it's a lot of focusing your eyes on a target and moving your head. It's important to note that these exercises are likely going to make you dizzy, especially in the acute phases. And they're meant to do so. It's the way I like to describe it is like muscle soreness for the inner ear. So when you're working out and you're lifting weights, if you're just lifting those 1 pound dumbbells, when you should really be lifting those 25-pound dumbbells, you're not going to get that muscle soreness. So if you're doing these exercises properly and you're stimulating the vestibular system, you will provoke a low level of dizziness that goes away when you rest. And that's like that muscle soreness analogy. So we actually want that, but we want it to go away as you rest. So we do this in all different directions, focusing on a target. We could do it with focusing on a target while walking forwards, backwards. There's a lot of different fun things we can throw at you. Turning your head without a target up and down, turning your head, walking side to side. And then again, if that vestibular system is compromised, then you're likely going to have balance impairments. So we do address balance as well, both statically, just standing, and dynamically with walking. This is kind of the balance progression from easiest on the left to hardest on the right. And then we'll do different things like standing on a foam pad to compromise that pressure system that we talked about, that somatosensory system. You might be standing on a foam pad with your eyes closed. You might have your eyes open, but you're turning your head. So we're exercising all three of these balance systems, depending on which one we're trying to strengthen. And then we have Meniere's disease, and it's thought to be a buildup of fluid or pressure in the inner ear. And what you might experience with this is sudden but severe attacks of room spinning dizziness. These usually last between 20 minutes to 24 hours. So again, it's really important to note how long your episodes are lasting, because it's going to cue us into the diagnosis. A lot of times these are so severe that they're associated with nausea. And it's rare, but in the later disease of Meniere's disease, in the later stages of the disease in Meniere's, you could have drop attacks without a loss of consciousness. Positional changes don't really matter. It's intermittent, it comes and goes, and it's unpredictable. You might have some hearing changes, but these are usually fluctuating. So fluctuating ear fullness or ringing in the ears, or hearing loss. And the diagnosis for this, again, based on patient report and symptoms, our clinical exam, and we also have diagnostic criteria, which is put out by the Meniere Society. And then in Meniere's disease, we usually, as we age, we lose those high frequency sensory neural hearing loss. But with Meniere's, we tend to see a low to moderate frequency hearing loss. So if we're suspecting Meniere's, then we might want to get a baseline hearing test or audiogram, so that as the disease progresses, we can detect if there's a change from baseline in those low to moderate frequencies. Treatment in the acute stages, medication, steroids, meclizine, Zofran, which is an anti-nausea medication. And then long-term treatment for Meniere's disease is low salt diet, diuretics or water pills, because salt causes us to retain fluid, and the issue with Meniere's disease is that there's an increase in the amount of fluid that we don't want, and it's putting pressure on the hearing or the balance nerve. Diuretics, which help to reduce fluid. Beta histine, I don't know if this is actually available in the US yet, but it's available in the UK and Canada. I've had some patients that have traveled to get these medications a couple times a year. And then vestibular rehab. And it's vestibular rehab is more geared towards education in this case. We can address the balance issues, but there's nothing we can really do to stop these intermittent and unpredictable attacks. It's more of kind of a lifestyle management thing. And then for vestibular migraine, it's a room spinning, non-specific dizziness, and it's usually associated with light or sound sensitivity or some type of visual aura. So whether that's spots in your vision or half of your vision is kind of cutting out. And then an important point to note is that it can be with or without a headache. So when we think of migraine, we usually think the head pain. But for vestibular migraine, it's actually affecting the vestibular portion of the brain centrally, and it doesn't necessarily have to involve that pain portion. And this dizziness usually lasts 5 minutes to 72 hours. Positions tend to not be contributory. With the episodes, you might have hearing loss or hearing sensitivity or ringing. And again, for diagnosis, back to that patient report, usually there's a history of migraines, whether it's a known recent history, or a lot of times it's back in childhood where they might say, no, I don't have migraines, I don't have migraines. And then you ask about growing up, did they have any dizziness or migraines? And they usually do at some point, or at least a history of motion sensitivity. And then we do our clinical exam, and there's again that Meniere Society criteria to help with the diagnosis. This is a tricky one though, because it's kind of a lifestyle management thing. So vestibular migraine can be triggered by kind of any one of these. It's usually not just one, it's a combination of a few. So there's stress as a big trigger of migraines. Dehydration can trigger. Poor sleep hygiene is huge. So if you don't have a normal sleep-wake cycle, then that can throw you into a migraine. Too intense exercise can trigger a migraine, but also not enough exercise. You have to find that happy balance. There was one study that showed that 40 minutes of aerobic exercise for 3 days a week was just as effective as taking migraine medication. Intense stimulation, so bright lights, loud noises, intense smells, or visual motion can be a trigger for some people. Hormonal changes around the time of the menstrual cycle, weather, atmospheric pressure changes, or significant changes in hot or cold. There are some potential food triggers, but again, just because it's on here doesn't mean it's a trigger for you. So I usually say it's good to keep a diary to kind of figure out what might be a trigger. And then some vitamins that have been helpful in migraine are magnesium, vitamin B2 or riboflavin, and CoQ10. And then back to this activity pacing, what's in your cup? It's kind of this threshold theory that I discuss. It's you start each day with an empty cup, but if you're not sleeping well, or you're anxious, you're stressed, you're worried, then you're starting your day with an empty cup. And you're kind of sub-threshold here until you hit that threshold where the cup overflows. So if you're starting with a half full cup, it's probably not a day that you want to do a 5-mile run, go to the grocery store, go to the grocery store, do your laundry, and clean your entire house, because that's probably going to put you above the threshold and it might spike a migraine. So just to review, with talking about dizziness, we have to talk about balance as well. So we have our vision, our vestibular system, our inner ear balance organ, and then our pressure senses of our foot to tell what surface we're walking on. All of these have sensory information coming in. They process it, send a signal to the brain, and then they give a command so that we don't fall over and maintain our balance and go about our day. So there are steps that we can take to reduce, to improve our balance and reduce fall risk. If we are dizzy, we're twice as likely to fall. Falling once doubles your chance of falling again. And it can lead to anxiety, social withdrawal, inactivity, and a reduced overall quality of life. And dizziness and falls are not a normal part of aging. So we're going to talk about these 4 bottom things briefly. But just a couple things to note. Some intrinsic risk factors for falling are increased age. If you've fallen before, or even if you have a fear of falling, it's been shown that you have increased chance of falling. Muscle weakness, inner ear dysfunction that we just touched on, walking or balance problems, poor vision, postural hypotension, so if you change positions too quickly, and then other chronic conditions can contribute, such as stroke, diabetes, Parkinson's, and dementia. Extrinsic risk factors include lack of stair handrails or not using the stair handrails that are provided, or stair design. So if the stairs are kind of different heights or different depths, could be a tripping hazard. Lack of bathroom grab bars, and that doesn't include the towel rack that's next to the toilet, because if you pull on that, it's going to pull out of the wall eventually. Dim lighting or glare, obstacles or tripping hazards, slippery or uneven surfaces, certain medications. So you want to talk to your primary care physician about the medications and make sure that there's no interactions. And then improper use or not using assistive devices or walkers. So with visual impairments, you have a 2.5 times increased risk for falling. 18% of patients 70 years and older have substantial visual impairment, and there's been an association between reduced visual acuity and hip fractures. Neuropathy, so that altered sensation or feedback in your feet increases fall risk among older and younger adults, and it can be associated with greater risk of injury from falls. And then this is one of my favorites, so muscle weakness. So strength and muscle mass declines with age, and muscle cells replaced with fat and connective tissue. Fat accumulation is associated with weakness, poor function, and mobility limitations. So if you look at the top picture here, this is a 40-year-old triathlete. What we're looking at is a cross-section MRI of the quadriceps muscle, so the thigh muscle. So if we take the thigh, cut it in half, and then flip it up, now you're looking down the leg. This dark portion is the muscle, and this white portion here is the adipose tissue or the fat tissue. And then we have the bone in the center. And then in the second picture, we have a 74-year-old sedentary man. All that white is that adipose tissue or the fat tissue, and we have much less quadriceps or muscle. And then we look at the 70-year-old triathlete. Again, we have this large muscle mass here, the quadricep muscle, very little fat, and that bone in the middle. And you can't even really tell the difference between a 40-year-old triathlete and a 70-year-old triathlete. So if you don't use it, you'll lose it, and that's true for your muscles as well. So steps you can take to reduce your fall risk: talking with your doctor, annual wellness exams, let them know if you're experiencing dizziness and be specifics about what that dizziness is that you're experiencing. Is it the vertigo? Is it the lightheadedness? Or is it the disequilibrium or imbalance? Let them know if you have had a fall, don't be embarrassed, or if you have a fear of falling, because again, this is going to increase your chances of falling again. And if your first fall didn't result in an injury, we don't want to take that risk in the future. Review your medications, make sure there's not any interactions, and you can be your own advocate and ask for vestibular therapy. Make your home safer, remove tripping hazards from the floors or walkways. That includes papers, books, cords, clothes, etc. Remove any area throw rugs. This is a big tripping hazard if the corner flips up and you end up tripping on it. Non-slip bath mats, proper lighting, night lights, especially if you're up to the bathroom a lot in the middle of the night. You're kind of half asleep when you're doing that. So you want to make sure that you have good lighting if you're getting up and going to the bathroom through the night a lot. Grab bars, again, that's not your handrail or your hand towel rack. Shower chairs and proper fitting footwear. Regular exercise, movement is medicine. It's recommended 30 minutes of exercise 5 days a week. But you don't have to start there today. You don't have to start there next week. Start small, build your way up. The best exercise is the one you enjoy. So make it enjoyable, exercise with someone, join a group or community exercise class. Silver Sneakers is a program that might be covered. You can ask your insurance about it, and it might cover some or all of your gym membership at a participating gym. But again, the best exercise is the one you can do. Motion is lotion, so you want to keep moving. Just a recap. For vestibular therapy, treatment depends on the cause of your dizziness. So we really want to find out what is causing it. And some of the goals are to resolve the BPPV, the crystal issue, reduce dizziness and fall risk, improve your balance, improve any visual disturbances with head movements if there's altered VOR or vestibular ocular reflex, improve your overall fitness level, increase your independence so that you can participate in social activities and improve your overall function and quality of life. What to expect if you do see a vestibular specialist. Be prepared to answer those questions. History is going to lead us to the proper diagnosis. We'll start with the neck screen to make sure that you can get into all of the positions that we need to test. We'll be doing a lot of eye exams, so looking at your eyes to see if in certain positions your eyes are doing an abnormal eye movement called nystagmus. A neurologic exam to make sure that this is actually coming from the peripheral vestibular system, and if it's that it's not more of a central issue that might need further workup, imaging, referral to a specialist, or immediate referral out to the emergency room. BPPV testing, so the positional testing for the crystals. And then at the end of each session, I like to educate, make sure that you understand what the findings of the exam were, and you leave with a lot more knowledge than you came in with. And that can include an ear model, pictures, handouts, etc. And then you'll also likely leave with some exercises to get started on day one. So how to get vestibular rehab: find a clinic with a vestibular therapist. Don't just go to a general physical therapist that doesn't really have any experience. We all get a base level to pass our board exam in grad school, but if you're not really treating it on a regular basis, then that's probably not the therapist that you want to go to. Vestibular.org is a good place to start. However, it is a paid site. So if you're not paying to get your name on there, like I'm not, you're not going to find the therapist. But if you talk to your doctor, there's a good chance that they have a vestibular therapist that they do refer to. At Torrance Memorial, I want you to know that because we're hospital-based, you do need a script from a doctor. But if you have a PPO insurance at private practice clinics in all 50 states, you can go to a physical therapist directly without a script from a physician. But for our clinic at this hospital, you do need a referral from a doctor. And then just to summarize, accurate history is most important. So know the difference between the vertigo, lightheadedness, and disequilibrium. Dizziness and falls are not a normal part of aging. Tell your doctor if you're experiencing dizziness and be specific if you're falling or have a fear of falling. And then vestibular rehab is an important part of recovery. And the treatment really depends on the cause of your dizziness. And keep in mind that what makes you a little bit dizzy helps to heal you. Thank you.
Wow, well, thank you, Tim. I don't know about you all, I sure learned a lot. Okay, we're going to take about a 10-minute break before question and answer time. And at the moment, we have members of the Miracle of Living Committee handing out any pieces of paper you might need to write questions on, writing materials, etc. And please avail yourselves of the opportunity. I don't know about you, but I sure learned a lot so far, and there's more to come. So, 10 minutes. Okay, as they say, I'd like to bring the meeting back to order. We have a goodly number of questions, and I think it's great because they are, from all sorts of different directions. Let me start with one from the listening audience afar. Can long COVID symptoms be the cause of vertigo or lightheadedness? Anybody want to take a whack at that?
Yes, we know we're learning a lot more about COVID. It's still new, but we know that COVID is a viral infection. And we also know that vestibular neuritis or labyrinthitis can be triggered by or caused by a virus. So there is the potential that that viral infection could attack the inner ear nerves. We also know that COVID affects a lot of body systems. So it's been shown to cause myocarditis or heart inflammation, which can be associated with lightheadedness. And it also affects other body systems. So absolutely. And that might not be a kind of one-stop specialty. That person with long COVID dizziness might have to see their cardiologist, their neurologist, their ear, nose, and throat specialist to try to get to the root cause of that dizziness.
Okay. Let's see. As I say, these are from all different angles. Here's one. Can prostate medicine cause dizziness?
So, I mean, in general, if a medication is newly started, and you start to have the symptoms just right after this new medication started, I would say it's definitely possible. But if you have been this medication for a long time, then I would think some other causes for dizziness as well. And by mechanism, I'm not very familiar with all the prostate medication, but I think a lot of them are having some side effects for lowering blood pressure. So if that was one of those type of medication, that definitely could.
Okay, thank you. Now, this is two questions from the same person, but they're tied together. My vertigo lasts sometimes for weeks at a time. Why? I feel fine as long as I'm lying down. Why?
That would be tough to figure out the cause of that if we don't have a more thorough history. Again, we'd want to figure out their entire medical history. And then there's also a lot of other diagnoses that we just did not have time to touch on tonight. So just because we touched on some of the main ones, there's a lot more out there. So I'd have a lot more questions to ask to try to figure out why that person might feel well when they're lying down, but not when they're moving around.
Yeah, here's another question in the same vein, I'm afraid. I have a question. I have a friend that got vertigo while driving on the freeway. What kind of vertigo is this, and will it happen again? Yeah.
Just think if it only happens on the freeway driving. Be very interesting if it only happens while driving on the freeway. I would suspect if it's anxiety related, but if it's related with like positional changes, yeah, definitely there are more possibilities. And we need more history, more information to find the diagnosis.
Yeah. Yeah, it seems one point that you've both made today is, a thorough history seems to be extremely important. Is it normal to have ear pain after the vertigo goes away?
I don't think, to my experience, it's not very common to have ear pain. You can have fullness and tinnitus, but pain is probably suggesting some like inflammation or some infection going on.
What help can you give someone who has both neuropathy and bad vision?
So one of the best things to do for neuropathy is exercise. So we would have to do a thorough assessment of their balance, a visual screen, make sure that they have an intact vestibular system. And then we would try to work with what we have. Sometimes we're not looking for a cure. We're looking either for improvement or to develop strategies to compensate for what systems that are not functioning properly. So there's different strategies that we can use to kind of retrain the way that they're going about their activities.
Yeah, and I want to add on is eye problem and neuropathy most of the time is two separate different things, but very rare situations like diabetes can cause two problems for the same disease. So probably go to see your eye doctor and the neurologist both and figure out a problem. Yeah.
Okay. Then I've got several questions in the same vein here. How long is the vestibular therapy? I think how long does it take to do that therapy?
It depends on what you're coming in for and what we determine the source of the dizziness is and the residual impairments. For instance, for the BPPV, the crystal issue, I would say the majority of patients are one and done. Sometimes I'll schedule a second follow-up just to make sure that everything looks good. And then for the vestibular neuritis or labyrinthitis, where you have an inner ear weakening, that takes more time for the brain to adapt. So we're doing weekly visits or every other week with you working on the exercises provided at home. And it can take weeks to months for that system to compensate. So it really depends on what we're addressing.
Okay, and well, I won't hazard my own guess at this, but from what you said, but can vestibular therapy be done virtually?
Yes, absolutely. Our clinic, we're busy enough in person that we don't take Zoom visits, which we used to do during the pandemic. But absolutely, it can get a little tricky just because when you're coming in for the clinical exam, we have specialized infrared goggles that we put on that shows a magnified version of your eyes on a screen. It records the eye movements when we take you into certain positions or do different tests, and we're able to play those back to if we want to relook at something to make sure that we're seeing what we're thinking we're seeing. So I would say it's probably better to go in person, but absolutely it can be done virtually over Zoom, and you can find places that will do Zoom evaluation or online virtual evaluations and treatments. Yes.
Are there specific exercises to improve peripheral neuropathy?
I think general exercise, cardiovascular exercises to promote blood flow and oxygen to the extremities, to allow nutrition to those nerves is the best thing. But there's not a specific exercise that is geared towards neuropathy.
Okay, and last question we have is, are there any community programs for vestibular therapy that you know about?
We have someone just mentioned over here about the booth. They have some yoga health community classes for yoga and balance. Any type of balance classes are going to be good, but specifically for vestibular or vertigo related dizziness, I don't know that I know of community classes for.
Okay, thank you. Thank you both. That's all the questions we have. We have, yes, ma'am.
Our initial evaluation is 1 hour. So that includes the history, clinical exam, the testing that we need to do to figure out or confirm our hypothesis from the patient report, and then education at the end and going over home exercises. It depends on what.
Let's see. The reason we take written questions is because nobody can hear you at home when you call out from that. Let me recommend that we end the official session and you talk to the doctors directly, because I think that's the best way to do it. Thank you all for coming very much. Thank you for watching, those of you that aren't here, and another round of applause for our speakers.
Coming.